Hello everyone. Let's move on to the MCQs. So we talked about in depth about the infective endocarditis in the morning session. So now let's move into the MCQ session. So a 28-year-old man with a history of intravenous drug use, okay, and presence with high grade fever. So the keyword what I'm going to see is IV drug use. There is fever chills for 5 days, which is nothing but acute, and is having tachycardia with systolic murmur, best heard in the left lower sternal border, and chest x-ray shows peripheral nodular opacity suggestive of septic emboli. Okay, see a few things which I can grasp from these MCQs is the patient is having acute infection, acute infective endocarditis. Patient is having a history of drug abuse, that is IV drug abuse, and patient is having lower sternal border, that is there is going to be murmurs, that is systolic murmur. So now breaking this down, IV drug use. IV drug use, the patient is going to put the injection in their veins. So they are going to carry the bacteria which is present in the skin flora, predominantly staphylococci, into the bloodstream, into the veins. So that is going to result in bacteremia. So this is going to result in taking of the bacteria, that is skin flora, into the venous, predominantly staph. One. Two is the patient is having acute infection. Acute, subacute. Acute is staphylococci, subacute is streptococci. Now, the patient is having systolic murmur. Systolic murmur is a classic of tricuspid regurgitation. So, the most commonly affected valve in staphylococcus infection is going to be tricuspid valves. So, tricuspid valve is the one that separates the right atrium and the right ventricle. So, the patient is having IV drug abuse, and the patient is going to carry the staphylococci. There is acute infection, there is tricuspid regurgitation, that is systolic murmur. So all these features are a suggestive of staphylococcus infection. Okay, so there is going to be staphylococcus aureus, acute infective endocarditis. Moving on to the next MCQ, a 52-year-old man with a history of rheumatic heart disease. Fever, fatigue for 6 weeks. Examination shows a pansystolic murmur, and the patient is having nodules in the fingertips, and there is a gram positive chains. Very simple. You're going to tell the diagnosis. History of rheumatic disease. So there is previously affected valves, newly affected valves, or fresh vegetations, staphylococci. Previously affected valves, viridon streptococci. So one, I get a clue that it is a previously infected disease. So I'm going to move towards streptococci, viridon streptococci. Now I look for other things which is supporting my diagnosis. Now it is the low grade fever is for 6 weeks, so it is not an acute, it is a subacute, that is weeks to months will be subacute. So again another one feature favors my diagnosis. Next one is there is pansystolic murmur. Systolic murmur, tricuspid regurgitation. Pansystolic murmur is mitral regurgitation. So in rheumatic heart disease, you see mitral regurgitation. So mitral regurgitation is a classic feature of Viridon's group of streptococci. That is subacute infective endocarditis due to Viridon streptococci. And there is painful nodules, oscillus nodes. So oscillus nodes will be because of the immune complex deposition. Prolonged exposure to, there is long antigen antibody reactions, there is going to be immune complex deposition. Okay, so pansystolic murmur with fever and chills for 6 weeks, and there is history of rheumatic heart disease, favors towards subacute infective endocarditis, already affected valves. Whereas systolic murmur with acute condition and IV drug abuse is a classic of staphylococcus infection, that is acute infective endocarditis. Now, a 64-year-old man underwent prosthetic aortic valve replacement 2 years before, and now presents with fever and malaise. Blood cultures are positive, and echocardiography shows vegetations on the prosthetic valve. See, a prosthetic valve, if you see, it is very similar to what is the biofilm what we form. So the prosthetic valve will lead to biofilm formation. So these kind of prosthetic valve biofilm are coagulase positive organisms, coagulase positive staphylococcus aureus. Okay, so it will be staphylococci epidermidis. Okay, so the staphylococcus epidermidis is very important because these organisms, They are mainly responsible for patients with prosthetic valves. So patient with the prosthetic valve and infective endocarditis, so these patients develop biofilm, especially coagulase positive staphylococcus aureus, which is nothing but staphylococcus epidermidis. Okay, it's a classic triad. Okay, now moving on to the next MCQ. A patient with a prosthetic valve replacement is planned for scaling and root planing. So what will be the best prophylaxis is, we all know that amoxicillin 2 grams 30 to 60 minutes before the procedure. Patient is allergic to amoxicillin, cephalexin 30 to 60 minutes 2 grams. And if the patient is not able to take orally, IV ampicillin 2 grams or cefazolin 2 grams. Now similarly, the patients with allergic to penicillin or cephalexin, we can give azithromycin 500 mg. So in this case, a prosthetic valve, similarly, there is no history of allergy, so I can give amoxicillin 2 grams 30 to 60 minutes before the procedure. Very straightforward, simple questions. You should never make mistakes in these questions. Now moving on to the last MCQ, a 60-year-old man has fever and progressive fatigue. So the blood cultures remain negative for 72 hours. And there is a history of farm animals exposure and unpasteurized milk intake. So echo shows vegetations on the aortic valve. Very confusing question. There is vegetations on the aortic valve. Vegetations means presence of endocarditis, because the endothelium is damaged. There is a formation of platelet plug or fibrin network. That is what we call it as vegetation. So vegetation is present, the infection is in the endocardium. So the endocardium is inflamed, endocarditis is present, but the culture remains negative even after 72 hours. Okay, this is a classic of what is called as the Coxella bruneti species. Okay, so these patients will have endocarditis, but the blood culture remains negative, because these organisms sometimes they are less susceptible, or they are not seen in the blood culture. So patient who is clinically confirmed that he or she is having endocarditis, but the blood culture is negative even after 72 hours, your diagnosis should be more towards Coxella bruneti species. Okay, so these are all the very few rare questions apart from the normal basic concepts of endocarditis. So this might be a rare exceptions, Coxella bruneti and also Staphylococcus epidermidis. So in the morning session we talked about the basics, and in the evening session we are talking about the few concepts which might also be asked. Okay, so I hope the infective endocarditis session makes sense, and you should never make mistakes in these infective endocarditis. That is one of the most commonly asked concepts in previous year questions. So thank you so much. Have a nice day.